First of all, thank you everybody for jumping on this call real quickly. I'll start off with, first of all, thank you to those of you that have submitted questions in advance. We'll try to get through all of those. But I'll start off quickly just with an update on where CHI Health is as a system today in terms of COVID patients. So we started this week with 87 inpatients. That's 5 less than a week ago. 10 individuals admitted awaiting test results. There's 33 of those 87 patients that are actually in the ICU, and there's 7 on ventilators. That's actually 7 less than 1 week ago. I know there's been a lot of focus and attention on issues of capacity. I will just point out that it's probably different by each health system, but the 87 patients we had starting this week is actually less than our peak, which was, it's about 20 less than our peak, which occurred at the end of April, on April 30th. So while we are seeing more patients admitted to the hospital than we did, 4 weeks ago, 5 weeks ago, I think as I've described before, what our data shows is these just kind of rolling waves of, more infections, less infections, requiring hospitalization. We also look at testing data and our, from our own in-house labs. As I mentioned last week, we've had some days where our test positivity rate was, up north of 15%, close to 20%. We've also had days where the positivity rate has also declined less than 10%. Last thing I wanted to address before I kind of start taking specific questions was this whole concept of capacity. So as I tried to describe last week, we manage capacity day in and day out, hour by hour, sometimes almost minute by minute. So to give you an example, yesterday in Lincoln and in our hospitals in Lincoln and in the Omaha Metro, just those 2 communities, we discharged over 150 patients from the hospital yesterday. We've got about 1,100 or so staffed beds. We average between 150 and 200 plus discharges and or roughly an equal number of admissions every day. So as we think about capacity, and I guess what I'm trying to impart on all of you and really the general public is capacity is literally something that we manage all the time. This is what we've done for the last couple of decades as we've tried to become more and more efficient, and it moves. So, at 8 o'clock in the morning, any given hospital might be, quote, full, but that's because there's 15 or 20 people waiting to be discharged that'll go home sometime between 10 or 11 o'clock in the morning and 3 or 4 in the afternoon. And so it is, at least with hospitals, it is something that, we all have had to learn to understand and manage. And so that's the thing that, I wanted to just share with you to start. The last thing I'll say about capacity is that, there's always a question about staffing, and we are not at a place yet where we're beginning to think about our, changing our staffing sort of approach and plan. Which is another way of saying, at this point, we don't believe we need to stop elective or non-urgent surgical procedures. We still believe that we've got the appropriate capacity and the ability to sort of flex and expand as needed, but it is absolutely something that we look at. We look at it, as I said, almost every day, trying to project forward where we think we're going to be tomorrow or a week from now, and make sure that we've got the appropriate resources to handle whatever the day may hold. So for instance, in Omaha, we've got less capacity this morning in Omaha than we do in Lincoln, Kearney, and Grand Island. And that, that's not atypical for an organization like ours that has 14 hospitals to have different sort of demand levels occur in different communities at the same time. So back like in the spring when we were dealing with the virus surges that were, the infections that were occurring out in central Nebraska, we had less capacity in Kearney and Grand Island than we did in Lincoln and the Omaha Metro. Today, we have more patients in the hospitals in the Omaha Metro than we do outstate. So with that, I'll stop talking at you, and then Taylor, if you would let me know what the questions are.
Yeah, so as Cliff said, we did get a lot of questions submitted ahead of time, so we're going to do our best to get through everything. The first question is, if CHI Health has excess capacity, how much of it is there and where is it?
Well, so I can tell you as of, this morning, which is the data that we get from our transfer center, we particularly COVID capacity, because as you know, in many of our hospitals, not all, we've actually set up COVID units or a specific area in the hospital where we'll try to keep all of the COVID patients co-located. In Kearney, Grand Island, and Lincoln, we actually have, good capacity available for COVID patients in those 3 larger hospitals out in central Nebraska. In the Omaha Metro, as I stated earlier, this morning we were more full. We were about 95% of our staffed capacity in aggregate across our Omaha hospitals, and that's it's a little different by hospital. So our hospital at Lakewood may have a couple more beds than our Mercy Council Bluffs hospital might have. We don't really within the Metro, we don't really look at them individually. We look at in aggregate and manage the capacity in aggregate across the Metro. And that's partly because we can move staff and we can move other resources as need be to really wherever the demand is. And we can also move patients, right? It's not uncommon if we can't care for you in the facility closest to your home, either because you need a higher level of care than is able to be provided there, or because of some resource constraint, we absolutely can move and do sometimes move patients within the Metro to one of our other hospitals that can actually take care of the patient.
Next question is, does CHI have plans to set up surge tents or hospitals, and have you done so already?
So short answer is no, we don't have any plans at this point to use surge tents or anything like that. I've shared before over the last 5 or 6 months, we have a lot of excess physical capacity. So if you just look at our hospitals, and we have literally large areas that have been built out but that aren't currently used because we haven't had demand. So for instance, our Midlands Hospital, I think we've got an entire floor of 28 beds that we could utilize if we needed. The challenge is staff, and how do you staff this extra capacity? So I think when we were doing our original surge planning back in March, we identified that we could expand up to about 2,000 beds from a physical capacity perspective. Granted, you've got to have the staff to be able to staff those beds, but just, the point being is that we don't need to set up tent hospitals because we've got plenty of bricks and mortar hospital capacity should we need it. Now, the other side of that question is, we are also watching the case counts and the numbers in Nebraska, and we have put in specific orders for additional, we call them traveler nurses or travelers, because there are these contingency labor companies that exist in this country that all hospitals use from time to time, and if we need them, we can go access staff that may not live in Nebraska but that will come and work and will come on a 13-week contract for us. So as of about a week ago, we've actually put in orders for more staff so that we are prepared should the trends continue up over the next 3 or 4 weeks, that we've got additional staff to help expand our actual staff capacity.
Next question is there a committee or entity designated specifically to decide which patients would take priority if the system's capacity is full?
No, but I guess the way I would really answer that, I'm not sure exactly about a committee. Within healthcare, there's always, particularly in times of crisis, the concept of triage always occurs, but not to decide who gets care or not. It's more of a question of, who are the folks that can be cared for and in what setting. And sometimes that process requires, our physicians, our staff to actually make a determination that a patient might be better cared for in another location at another facility with different capabilities. But, if the crux of the question is, are we worried that people are going to not have access to medical care should the virus infection rate increases? And I would say, no, I'm not worried about that at this point at all. And I've said in prior conversations, even last week, if in fact we got into a real crisis, which I think is what folks are mostly worried about, there are all sorts of things we could do to, quickly expand our capacity. Stopping our non-urgent surgeries would provide us more nurses that we could use in a crunch to be able to provide care for patients that required hospitalization, right? So we're not doing that today. That is definitely a tool in our toolbox should we need it over the next 3-4 weeks or even into this winter. But I'm not worried about that at this point. We're not expecting that. I mean, do we plan for some of those contingencies? Yes. The other side of that, I would just say is, and I mentioned this last week, and this is different. For us, what's harder to react to and respond to would be like a tornado hitting one of our communities, because that is a significant, increase in demand of hospital services in a very short period of time. That one is a little bit harder because systems can be overwhelmed. We're not there with this, where we are with the virus today. This happens, day over day. We've got time to begin to see trends and to plan for the future, even though we can't predict, what our numbers will be 3 weeks from now.
Has CHI outsourced any staff or expertise throughout this pandemic?
So I'm not exactly sure I understand the question. We have, we don't know of any of our staff that at least, by our doing have left to go care for COVID patients elsewhere in the country. We've done what we can do to hold on to all our staff. That doesn't mean that there aren't nurses that live in Omaha or actually live in Nebraska that haven't taken, 2 weeks of vacation and gone and worked as a traveling nurse in some other community. I'm sure that's happened, but that's not something, we've A, promoted, or B, actively know about.
Tell us what CHI Health is doing to help rural communities fight this pandemic, and has any staff moved around from anywhere in the area to assist with other clinics or hospitals within the system?
I've mentioned before, back in late April, early May, there was some movement of resources. We moved things like ventilators out into to Grand Island and to Lincoln to make sure that they always had excess capacity from a ventilator perspective. We've had some staff that have moved around to help out. In particular, we have a group of translators, our language services team, and we had folks from Omaha go out and help support the teams in Kearney and Grand Island. But more often than not, when staff move about, it tends to be within hospitals within the metro or sometimes even to Lincoln. As a large health system, though, that's one of the benefits that we have. We can move folks across our 14 hospitals should we need to. We also now have all of our hospitals on the same electronic medical record system, so that makes that even easier to do should we need to do that. But as of yet, it's not become something that we've had to really do in any significant degree.
If capacity at St. Francis or Good Samaritan reaches April levels, do Omaha and Lincoln hospitals have the room right now to receive patients from these hospitals?
Well, so as I said, as of this morning, it would be different today than it was a few months ago because we're more full in Omaha than we are actually in Kearney, Grand Island, and Lincoln. The way we would manage a situation like that, I think we've talked about this before. We have what we call a transfer center. So we have essentially a phone number that anybody can call, any hospital can call when they have a patient that needs to be moved to a higher level or a different level of care. We've used that internally for our system and our rural hospital partners for years. We've now made that capability available for the state as the kind of the state hotline transfer center. And so, there are always challenges, right? Because if you're in an outlying community and you have a patient that you think needs to be moved, and you call and, hospital X or Y or Z, isn't able to just say, yeah, send them right now. There's always a little bit of that goes on back and forth. But generally, as I said, we're constantly having patients discharged from our hospitals. So even if a given hospital, whether it's a CHI Health hospital or some other hospital, if a given hospital's, quote, not able to accept a patient at 10 o'clock in the morning, they may very well be able to accept that patient, at 1 or 2 in the afternoon. And the transfer center is a tool that we've made available for the rest of the state to help facilitate and make that process as easy as possible. Is it perfect? Probably not, but it absolutely is designed to really support those rural community hospitals. Now, the other thing I would say, though, is that maybe different than at the beginning of this pandemic, what we're seeing with the patients that are infected with the virus, we're not seeing the same degree of illness, the not as much ICU requirement, not as much, for sure, fewer patients on ventilators. Maybe it's because we have some treatments now that we know can forestall the worsening of the illness. We've all gotten better at caring for patients. And so my point being is a lot of the folks that end up requiring, short-term hospitalization can be effectively managed in a smaller rural facility. And many of our rural facilities across the state are actually doing a great job of taking care of patients close to home. And so we're also a big proponent of that. Just because you're infected with the coronavirus does not mean you need to be in a hospital, and it for sure doesn't necessarily mean you need to be transferred out of your community necessarily. So we're blessed in this state by the fact that we have a lot of very strong, very talented clinical staff in our rural communities, and for the most part, they've been able to handle and care for perfectly the vast majority of COVID patients that have shown up in their hospitals.
Are Metro CHI Health hospitals transferring patients to smaller hospitals right now?
Not as of this moment, no. I mean, there's this discussion about within the Metro about moving people, say, from the Creighton University Medical Center if we needed to Mercy Council Bluffs, and so that capability exists, and we're perfectly able and willing to do that should demand necessitate us moving patients around. But for the most part, we've been able to take care of the patients that show up in one of our emergency rooms at that facility that's closest to where they live.
At what point does CHI Health consider implementing restrictions we saw in April, like postponing elective surgeries as cases rise with hospital capacity declining? If that is the case, how close or how long do you predict it will take?
So one of the things I think we all learned going through this first few months of the pandemic, when we didn't know as much about sort of the virus and how to care for these patients when we were really dealing with something that was novel, I think we've all learned that there was significant risk we put our communities at, patients in our communities, by delaying care that they otherwise needed. And in fact, I actually push back on the word elective surgeries. A lot of people talk about canceling elective surgeries. And quite frankly, there are very few things that we do, that our surgeons, our physicians do, that are truly elective. I mean, there may be some things like cosmetic procedures that you might consider them elective. Really what it is the difference between something that is urgent, meaning this is kind of a life-saving surgery that needs to occur right now, versus something that I would describe as non-urgent, which means it's still needed. It's not elective. It's medically indicated, but it's something that could wait 5 days or a week or 2 weeks. I think what we've all learned is we cannot put patients at risk who have other medical conditions because we're trying to also manage patients infected with this novel coronavirus. So we will If we get to a place where our clinical leadership says, we've now pushed to the point where we really need to preserve additional capacity for future, admissions, for COVID admissions, then we would absolutely stop the non-urgent surgeries and procedures. But we're not there today. And as I said, we look at it every day, and our clinical leadership makes a decision on, are we good to continue to go? What about tomorrow? What about the next day? And make those decisions day in and day out. But what we're trying to avoid is shutting down the entire health system and not delivering care to people that otherwise need it, because we're worried about the few more viral infections that need to be admitted to the hospital. So I hope that answers the question. And again, I wish there was a black and white answer for you. There isn't one, but we know, and I think we know, we're going to know more and more over the next 6 to 12 months, some of the negative impact from a health perspective that occurred as a result of us sort of shutting down everything and people either avoiding or forestalling necessary care. Those folks are just as much a concern to us as patients that get infected with the COVID virus.
At some hospitals, there's capacity depending on level of care. What do you mean by level of care? Is there certain spaces that are at capacity?
So the level of care question, the way I would describe that is, if I was infected with the coronavirus, I could be completely, ambulatory, meaning I'm fine, I'm at home, I'm taking over-the-counter medicines, and it runs its course over a few days. I don't require oxygen, I don't require, IV fluids or any other treatment, so that's the kind of the self-care level of care. We don't admit people to the hospital that don't require something that can only be provided at the hospital. So the next level of care would be somebody that's a little short of breath that requires some oxygen, right? So that would be, somebody that might be admitted to the hospital for a few days until they were able to not be short of breath or their oxygen level returned to normal without supplemental oxygen. We're learning more about this virus, but there'll be other folks that maybe get sicker quicker, and those people would be candidates for other treatments that we know works, dexamethasone, remdesivir, et cetera. The ICU is really reserved for people that are significantly ill. They're seriously ill, whether they require mechanical ventilation, so breathing assistance or not. The ICU is where we put the sickest of sick patients, and so within a given hospital, CHI Health or other, your med-surg units might be full, but your ICU may not, or your ICU might have only one bed available, but you've got 30 beds available in your medical surgical unit. And so if somebody shows up and they need an ICU, then it's your ICU capacity that matters. If somebody that shows up and they just need some oxygen for a couple of days, then all they need is a regular hospital room, and they can be put anywhere basically within the hospital. So yeah, the level of severity of illness will dictate where the patient needs to go from an admission perspective, and then that obviously is dependent on that given facility's ability to provide that space. So you might show up at a hospital, and if you only need a regular hospital bed, they could admit you, but if you need an ICU bed, they may have to transfer you to another facility that had an ICU bed, assuming that their ICU was full. But we do that not only as a CHI Health system, but we do that as a community. So if patients need to move from us to Methodist or Nebraska Medicine or vice versa, we absolutely work with our partners in the community to make sure the patients get the care they need in the appropriate location.
How is staff holding up?
I mentioned this in our call last week. The best thing you all can do is just continue to recognize the caregivers, not only CHI Health, but really across the region. It's been a long 6 months, and I think it's safe to say that they're fatigued. We're all fatigued. I think everybody's getting a little tired of this pandemic, and yet I also know that when they are called upon, when they are needed, they are they're the first ones to volunteer to turn around and walk right back into the clinic or the hospital to do whatever needs to be done for their community members. They were called to this profession, and it truly is a calling. And this is a time when that calling is demonstrated, over and over again. And so I just encourage folks to, not only thank the caregivers that you know, but do the things you can do to help slow the spread of this virus, to really be careful about distancing, to wear a mask when you can't distance, to wash your hands, get your flu shot. Those basic things will go a long way towards supporting the caregivers in this region.
We had a question pop up in the chat. We hear about capacity reported only in terms of bed capacity and ventilator capacity. Why isn't staff capacity mentioned? Should it be?
Well, staff capacity is a component of it. I guess we're mentioning it today. I've mentioned it in the past that physical capacity is one thing, staff capacity is another. Staff capacity though can flux and change across all organizations, right? So our health system, just like others, are not immune to employees who live in the community, obviously picking up, getting a sniffle or a sore throat one morning and having to call in because, they have all been very well educated that if they have any symptoms at all or have any exposures at all, that we pay them to stay home. So staff capacity is also a function of what's going on in the community in terms of the infection rates. So, that's the other piece that those of us on the health system side are trying to, we also have to manage it day in and day out. Because it, the staff is the principal part of our capacity besides the bricks and mortar. We can offset, the issues as far as if we start to feel like we're bumping up against staff capacity through bringing in contract labor, which we're doing. I know all of the systems in the metro are doing the exact same thing. And so, it is, that's not something that is kind of novel to us, and it's not really unusual for those of us in healthcare. The other thing I would say about staff, because people have asked, I've been asked the question about, well, how come you don't have a bunch of extra staff around? Well, because if you think about it, in healthcare, our revenues, our money is your money, and it's your insurance dollars, it's your tax dollars. And so we've spent the last 2 decades learning how to be efficient and not have waste, not being wasteful, not having resources that aren't being utilized, that aren't necessary in a given moment. And so we've all learned to staff for what are our normal, volumes of patients on any given day. But unfortunately, within healthcare, we can go from, one day we can have 100 new admissions to our hospitals. The next day we could have 300. We can't always predict it. We can't always prepare perfectly for it. And so, the way we've managed that over time is learn to use the contract labor to staff up in times of extra need. So long answer to your question, but staffing is a very big part of our capacity, but it's just one piece. We're blessed to have plenty of physical capacity, and we think we'll have within the next couple of weeks plenty of staff capacity as we bring in outside resources.
Okay, Cliff, last question. It seems as though there's a feeling of panic in the community for some. Is it time to panic?
No. And I'm not saying that just as a physician and in somebody that is involved with a health system here in the community. I'm saying that as just an individual. We've got some of the best healthcare in the country in our region. We are blessed to have, hospitals, be they rural, be they large academic medical centers like Creighton University Medical Center, be they, community hospitals that are perfectly capable of providing the care that our communities will need. We have a governor and a chief medical officer of the state who have been incredibly helpful and proactive in working with those of us on the health delivery system side to make sure that we are prepared to care for the community, however the community needs to be cared for. So I'd strongly encourage people not to panic. That doesn't mean you can ignore the things we know lessen the spread of this virus, but there's no reason to panic at this point for sure.